Wow, how to start after such a incredible introduction. Thank you, Ed. It's an honor today to be able to present to you, and particularly this topic, neonatal cholestasis, which I'm doing as a representative of my organization, NASPGHAN. It's a mouthful, North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. This program was developed by experts in the field. They have nothing to disclose. I am presenting it with some modifications and additions, and I have nothing to disclose. The challenge. Cholestatic jaundice affects about 1 in 2,500 infants. It's always pathologic, and it indicates liver dysfunction. It may not be recognized by primary providers in the setting of physiologic jaundice. Early detection by the primary care physician and timely referrals to a pediatric gastroenterologist or hepatologist are important contributors to optimal outcome. The learning objectives of this presentation are to understand the differential of neonates presenting with conjugated hyperbilirubinemia or neonatal cholestasis, describe the signs and symptoms, know the importance of early diagnosis on outcome, perform appropriate testing for rapid identification and review screening efforts, and describe the appropriate tailored disease-specific treatment methods, including optimal nutrition. This is the definition of cholestasis. It's reduced bioformation or bioflow that results in retention of bile and biliary substances that should normally be excreted and destined for elimination in the intestinal lumen. It's typically recognized by elevation of the serum conjugated, a la direct, bilirubin and bile acid levels. This is a case study of an infant with fairly extreme symptoms of neonatal cholestasis. Some of these infants are not going to look like this. Many of them will look reasonably normal with only slight jaundice as their only symptoms. This had been a healthy full-term infant presenting at 4 weeks of age for evaluation of jaundice. The physical exam showed a normal appearance but deeply icteric, alert, vigorous infant. Positive findings were hepatosplenomegaly. There were abnormal laboratory tests of enzymes, AST, ALT, and GGT. The bilirubin, unconjugated, was 3.1, the conjugated, 20.1, and bile acid level was elevated, clearly an infant with cholestasis. This presentation is going to focus on the differential diagnosis of such infants and how to evaluate. Bioformation is a very complex process. It involves a lot of enzymes, a number of membrane transport systems that are ion transport and organic solute transporters. The transporters may be on the sinusoidal membrane of a liver cell or the canalicular membrane. This cartoon shows a liver cell, 2 liver cells. Their membranes form an enclosed area, space, called the biocanaliculus. This is the path that the bile first takes, and here indicated are examples of several of the transport mechanisms that take the bile products like bile salts from the liver cell into the biocanaliculus. The biocanaliculus connects then through to smaller bile ducts that become larger and larger that eventually connect to a definable larger bile duct that's very easy to see. Bile flow is directly related to bile acid excretion by the liver cell. Bile acids are formed from cholesterol. There's a series of many enzyme steps to go from cholesterol to bile acids that are excreted, cholic and chenodeoxycholic acid. Bioformation, then, to summarize, is a number of steps and processes in the liver, then excretion of the bile into the bile duct, into the duodenum, on into the intestine, where it travels to the terminal ileum, where selective products of bile acids and bilirubin are reabsorbed. We're now going to discuss some of the medical and surgical conditions that are associated with these pathologic processes along the way that are associated with neonatal cholestasis. This is what neonatal cholestasis looks like in 2016. 10% with neonatal hepatitis, 10% with alpha-1 antitrypsin deficiency, 25% with a category of multiple diagnoses for intrahepatic cholestasis, 25% with metabolic disorders, 25% with biliary atresia, and 5% with defined viral infections. Neonatal hepatitis, 20 years ago, actually used to be our biggest category. It meant, really, we didn't know what the cause was. This black box of neonatal hepatitis has shrunk now, and it's shrinking further as we define more and more specific causes, largely genetic ones. Idiopathic neonatal hepatitis can be sporadic or familial. There may be a defined viral cause, with cytomegalovirus being the most common. Others include herpes, echovirus, enterovirus, rubella, adenovirus, and parvo B19. Bacterial infection, like sepsis, can present as neonatal hepatitis, as well as urinary tract infections. Metabolic disorders include alpha-1 antitrypsin deficiency, GALD, gestational alloimmune liver disease, formerly called neonatal hemochromatosis, amino acid disorders like tyrosinemia, carbohydrate disorders, galactosemia, storage disorders like Niemann-Pick, urea cycle disorders, and mitochondrial disorders. Alpha-1 antitrypsin deficiency is caused by abnormalities in a single gene, SERPINA1. The protein that it makes is alpha-1 antitrypsin. The function and the problem that happens is accumulation in the liver of a mutant alpha-1 antitrypsin molecule, generally can be labeled as phenotype PIZZ in the hepatocytes. This is what causes the disease. Its activity in the blood is to deactivate and be an antiproteolytic for proteases in the blood. So two things happen. Abnormal alpha-1 antitrypsin remains in the liver, causing disease, and there's inappropriate and low levels of the antiprotease activity in the blood. This leads to the lung disease associated with alpha-1 antitrypsin deficiency. This demonstrates the function of the molecule. Here is alpha-1 antitrypsin. Here is a protease. The alpha-1 antitrypsin goes out and captures the protease and then deactivates it. Now the molecule's dead. It is the most common cause of inherited neonatal cholestasis. 10 to 15% of neonates with alpha-1 antitrypsin deficiency present with cholestasis, hepatocellular injury, and elevation of enzymes and alkaline phosphatase levels. The diagnosis is made based on the phenotype, which is identified from isoelectric focusing in the laboratory, and abnormal phenotypes are ZZ or SC for infants. Although there are some other abnormalities, those abnormalities do not cause cholestasis. Another area is cystic fibrosis. This is also a specific genetic disorder. The gene is CFTR. The protein it produces is CFTR. This protein affects the chloride channel and the transport of chloride from cholangiocytes into the bile. Therefore, the bile becomes very thick if you can't transport chloride into the bile. Here again is this cartoon. Here we have the biocanaliculus and its transporters, and CFTR is located here in the cholangiocyte, and it makes its effect clearly on the bile ducts. Endocrine disorders. Pituitary and thyroid hormones are involved in the regulation of bile acid synthesis and excretion and bile flow. Neonates with panhypopituitarism may present with elevation of bilirubin levels. Affected infants may in addition have septo-optic dysplasia, presenting as wandering nystagmus and an inability to focus, and they will have abnormal CT or MRI studies of their brain. Diagnostic evaluation is very simple. TSH, total, free T4, morning cortisol levels, brain MRI where appropriate. Cholestasis in the liver disease completely resolves with correction of the pituitary hormone deficiency. I've told you about several intrahepatic associations with cholestasis. We're now going to discuss several cholangiopathies, meaning bile duct obstruction. You will hear me mention a number of things about biliary atresia. Choledochal cysts, inspissated bile means thickened bile that gets in these little bile ductules, for example, from hemolysis, biliary sludge, gallstones, cystic fibrosis, and tumors. Biliary atresia is a neonatal disease characterized by destructive, inflammatory, obliterative cholangiopathy. It can affect various lengths of both the intrahepatic and the extrahepatic ducts. Here's the bottom of the liver, an atretic gallbladder, cystic duct, and atretic common bile duct entering the duodenum. It can be classified as non-syndromic, which is most forms, or syndromic. Syndromic can mean at least one malformation, but no laterality defects, such as situs inversus, or with laterality, which is 10% of patients. Commonly, splenic malformations are present. Cardiovascular and other gastrointestinal malformations, particularly malformation, are common. This photo shows multiple spleens. This is the biliary atresia splenic malformation syndrome. There may be multiple spleens or asplenia. Portal vein position is abnormal. Situs inversus, either complete or total, can occur, malrotation, and cardiac abnormalities. Seeing this on ultrasound and radiographic studies or by exam in a child with jaundice strongly indicates the presence of biliary atresia. The etiology of this important condition is unknown. Theories include genetic contributions to bile duct dysmorphogenesis, viral infections, toxins, chronic inflammatory and autoimmune-mediated bile duct injury. The treatment needs to be applied within the first 60 days of life for effect. The treatment was developed more than 50 years ago by Dr. Kasai, the Kasai hepatoporta enterostomy, aimed at reestablishing bile flow by dissection of the porta hepatis to the level that there are bile ducts and constructing a Roux-en-Y limb for drainage of flow. Choledochal cyst may also be identified by ultrasound and presents with neonatal cholestasis. Patients may have cholangitis and present with fever, elevation of the conjugated bilirubin and GGT. The ultrasonographer can often identify the cyst. The bile ducts are typically dilated, but occasionally it is also associated with biliary atresia with an atretic gallbladder. This is a category of intrahepatic cholestasis that we have not covered. It includes disorders of bile acid synthesis, disorders of membrane transport, of embryogenesis, example, Alagille syndrome, and miscellaneous, such as those who have heart disease independent of biliary atresia or Alagille's syndrome, sepsis, drugs and toxins, and a number of unclassified syndromes. Inborn errors of bile acid biosynthesis are extremely rare disorders. We follow 2 living children here and 1 child who required a liver transplant because the disorder was diagnosed very late. The true incidence isn't really known. We know it's rare. It may be as rare as 1 in 100,000. It occurs because of a block somewhere along one of those enzymes that I've already showed you. That block in synthesis therefore results in underproduction of the primary bile acid, cholic or chenodeoxycholic acid, which is necessary for bile excretion. And the block also at the same time results in overproduction of the toxic bile acids. The end result is cholestasis and liver disease. This condition is unique and can be suspected because total serum bile acids, rather than being high, as you would expect in a cholestatic disorder, are actually low because they're not being formed. It is also associated with a low GGT level, and GGT levels are frequently elevated in other cholestatic disorders. Why care about such a rare disorder? Because we care about it, but also because it has treatment that, for the most part, controls or cures it. Prompt diagnosis can result in successful treatment with the end product of bile acid synthesis, cholic acid. This is now available as an orphan drug, and administration results in nearly total resolution of the histologic lesions. Many of these are new disorders. These are called progressive familial intrahepatic cholestasis mutations. There are now 5. The newest one was added, type 5, in 2015. Each disorder is associated with a genetic mutation that affects a transporter, a membrane transporter of a substance or bile acids that then has an adverse effect on the liver by retention of bile. They have different histologic pictures and severity. Here is PFIC1, the oldest one. It has been called Byler's disease. It was first described in Amish kindred. And you can see generally minimal inflammation here. Here is PFIC2 with nodular formation. PFIC3 has a lot of scar tissue and a lot of inflammation. PFIC1 involves the FIC1 transporter and an abnormality and mutation, which are many in this gene. This transporter is responsible for transport of aminophospholipid into the canaliculus, and if absence of effective transport results in biliary retention and liver inflammation. The bile is notably abnormal on electron microscope, and it's called Byler bile. It is very granular. PFIC4 involves the tight junction between the 2 hepatocytes and was fairly recently discovered in around 2013. And this tight junction malfunction also results in cholestasis. I'd like to tell you a patient story of patients here. An infant girl presents at 6 weeks of age with pigmented stools, jaundice, and hepatosplenomegaly. Her direct bilirubin is elevated, and she has elevated enzymes. She had a severe coagulopathy. All the usual studies to figure out what is wrong with her liver were negative. She had a normal gallbladder, no cyst, and her HIDA exam used to evaluate whether this could be biliary atresia excretes. Her biopsy looks like neonatal hepatitis. A sibling is born with similar symptoms, born 2 years later. Genetic evaluation is negative on these children for the things that we're able to identify. They develop severe pruritus. This is treated with biliary diversion. And now, 5 years later, approximately 18 months ago, this new disorder called PFIC4 and tight junction protein abnormality was identified through exome sequencing, both in London and here with our confirmation. So this is an example of patients right here taking patients from the black box of neonatal hepatitis to a firm diagnosis. These patients are the first ones that we know of that have been treated effectively with biliary diversion, which results in an inability to reabsorb your bilirubin and bile acid products for their pruritus, and it's also helped their liver disease. We know that other children have developed hepatocellular carcinoma, so we're now screening these children for hepatocellular carcinoma because we know what their diagnosis is and because we know they have a risk for it. These transporter mutations could be important as polymorphisms in other conditions that are acquired, such as TPN-associated cholestasis, sepsis, and cholestasis that occurs with that. Drug-induced and intrahepatic cholestasis of pregnancy is known to be associated with the PFIC3 mutation. Alagille syndrome is an autosomal dominant multisystem disorder which in the liver is characterized by interlobular ducts. Its prevalence is 1 in 30,000 live births. It's associated with mutation in JAG1, a transmembrane cell surface protein that interacts with Notch receptors to regulate cell fate during embryogenesis. Mutations can also be possible in Notch2. The penetrance is variable. The effects are on the heart, on the liver, on the bones, where a hallmark can be butterfly vertebrae due to lack of fusion. 97% of children have unique but nonspecific faces with a triangular face, deep-set eyes, some hypertelorism, and a kind of rounded nose. Eye exam shows this abnormal persistent embryologic structure, which is functionally non-significant but called posterior embryotoxon. 14% have abnormal cerebral vessels with a risk for intracerebral hemorrhage as they get older. The diagnosis is based on these clinical manifestations and confirmation with sequencing of JAG1 and Notch2 genes. Mutations are present in 95% showing JAG1 and 5% showing Notch2. How do we diagnose these? First of all, cholestasis must be recognized from first jaundice and then appropriate testing. Recognize treatable causes. Exclude biliary atresia. Differentiate intrahepatic cholestasis subtypes. This is a critical clinical practice guideline of this presentation and my organization. Any formula-fed infant noted to be jaundiced after 2 weeks of age should be evaluated for cholestasis with measurement of total and conjugated direct serum bilirubin. Some of the laboratories, when you order bilirubin test, give you only the total. Measurements of bilirubin should be fractionated into unconjugated indirect or conjugated direct hyperbilirubinemia. Conjugated direct hyperbilirubinemia of greater than 1 milligram per deciliter is considered pathological and warrants further diagnostic evaluation. The initial evaluation focuses on excluding these things. Is the infant look sick? Is sepsis the problem? Congenital infections, alpha-1 antitrypsin deficiency, cystic fibrosis, galactosemia, tyrosinemia, other metabolic problems, and this can be identified almost always by just reviewing the neonatal metabolic screen in newborns and endocrine disorders. Prenatal history, ultrasonographic findings can actually be presence of a choledochal cyst. We need to check, were there any prenatal abnormalities? Cholelithiasis, abnormal bowel rotation. Cholestasis of pregnancy can be seen in heterozygotes for some of these PFIC gene mutations and in mitochondrial disorders. Acute fatty liver of pregnancy is seen in LCHAD deficiency, and maternal infections can predict TORCH. Gestational age, prematurity. Biliary atresia is more common in premature infants, and they overall have an increased risk of neonatal cholestasis and SGA with congenital infections. Hemolysis, such as G6PD deficiency, results in an increased bilirubin load. Hydrops also increase bilirubin load. Neonatal infections, urinary tract infections, can result in cholestasis. Newborn screens, look for these abnormalities, which we so carefully screen for in children. A thorough physical examination is crucial to the proper evaluation of the jaundiced infant. Particular attention to hepatosplenomegaly and an ill appearance. You may also be able to suspect laterality abnormalities by where do you hear the heart sounds or where do you feel an enlarged liver. Direct visualization of the stool is a key aspect of the complete evaluation of the jaundiced infant. A laterality defect suggests biliary atresia. Pulmonary symptoms suggest cystic fibrosis. Bone malformations can suggest the ARC syndrome. Cardiac defects, Alagille, and biliary atresia. Specific tests may lead you to a diagnosis. For example, a T4 and TSH serum cortisol abnormalities may suggest panhypopituitarism. A sweat chloride or CFTR analysis. A serum ferritin is abnormal in several conditions like neonatal hemochromatosis and macrophage activation. Metabolic screens for confirmation, and viral studies as well as hepatitis B, HIV, and VDRL in appropriate high-risk patients. All patients should have an index of their liver synthetic function evaluated with a prothrombin and INR. Cultures as appropriate of blood, urine, and CSF. Serum bile acid levels that are normal or low will suggest a bile acid synthetic defect, and serum electrolytes, glucose, metabolic problems. The importance of looking at the stool. It is not just gastroenterologists that have to do this. All of you do. This is an example of a stool card that is used for screening in some countries to get patients with liver disease to liver doctors for further evaluation. Okay, the top three here are abnormally light stool colors, and beginning here, this is normal. I guarantee you that if you ask most of your patients, what color is your baby's stool, they will say it's yellow, it's fine. And then when you look at some of these babies with neonatal cholestasis, you will see it clearly is not fine. This stool card has been used in Japan. 300,000 infants were screened, and parents and caretakers sent back the stool card. And 34 children with biliary atresia were identified early and had appropriate care. The sensitivity of this card is 77% and specificity 99%. For those that don't have a specific diagnosis, but often done in parallel, we do an abdominal ultrasound. Chest X-ray is also done to evaluate the heart for abnormalities and the vertebral bodies. Another guideline is that non-invasive first diagnostic imaging investigation to look for obstructive lesions of the biliary tree is an ultrasound. It also can assess for signs of advanced liver disease, vascular and splenic abnormalities. Many, but not all infants with biliary atresia have a small or undetectable gallbladder. This is a red flag when it's found. Another approach that can be done for biliary atresia to suggest the diagnosis is a HIDA test. In this test, a nuclear label is injected into the blood, which is taken up by the liver and then excreted. The pros for using this test are that it is 100% specific to rule out biliary atresia if you see the label in the small bowel. There's little institutional variability in the study. It can be done in most hospitals. The cons are it's not timely. In most institutions, the protocol is to give a choloretic like phenobarbital or ursodeoxycholic acid for at least a day to complete the study. And non-excretion is not diagnostic. It could still be liver disease and not biliary atresia. Here are examples of the HIDA scan. This is a HIDA scan where the label was taken up by the liver and not excreted in the bowel. This is the label in the bladder. Here's a normal HIDA scan where it was taken up by the liver and excreted in the bowel, and here is some in the bladder. So again, this test excludes biliary atresia. This one does not. It is not specific. It could be other liver disease as well. But there are times where it's very helpful to know this is not a surgical problem. Our most important diagnostic test is liver biopsy. It can be done in a timely way, is extremely sensitive for the diagnosis of biliary atresia, and may point to other diagnoses as well. There is a morbidity and small mortality risk to the procedure. If performed too early, the findings may be nonspecific and false negative. You need an adequate sample. It requires an experienced pathologist, and it requires anesthesia. In the hands of an experienced pathologist, the findings histologically of bile duct proliferation, bile plugs, and fibrosis in an appropriately timed liver biopsy is the most supportive test in the evaluation of the infant with conjugated hyperbilirubinemia to rule in or out biliary atresia. This is a biopsy. This brownish colored pigment in the circular structure is bile within the small bile duct. This blue color here is fibrosis, and within here, all these little bile ducts. These are hallmarks of biliary atresia on liver biopsy. This biopsy shows these big, gigantic cells, fused cells. This is neonatal giant cell hepatitis. Nonspecific, but for exactly what caused it, but all the same giant cell hepatitis. And we talked about alpha-1 antitrypsin deficiency. Here's the biopsy stained to show retention with this red substance here of the abnormal alpha-1 antitrypsin molecule. What to do when the child's been evaluated for biliary atresia and all the specific tests as indicated, and there's still no diagnosis. You send a metabolic specialized genetic testing panel. This is an example of one of the largest. You send a sample of the child's blood, and they tell you about mutations in 57 different genes. You may say, why not do that in the beginning? Well, it's quite expensive, and it takes time. And the evaluation of the child with cholestasis cannot wait for 3, 4, 5 weeks for this test to get back. But This has enabled us to take children from the black box of neonatal hepatitis, or we don't know what you have, to specific diagnoses and exome sequencing to even further heights. So in summary, what I have told you is that it's important to evaluate the jaundiced infant early, do specific tests, which you can analyze in a day or so, and look at the metabolic screen. And then you must ask the question, is there biliary obstruction? Liver biopsy, a HIDA test, and a cholangiogram identifying the pattern of the bile duct will identify whether there is obstruction and if surgery and a Kasai hepatoportoenterostomy is necessary, or potentially another diagnosis like choledochal cyst, or there is no obstruction, and then you need further medical evaluation to define what the condition is. The treatment. There are some disease-specific treatments. We talked about the importance of the Kasai. It must be performed promptly. An operation for biliary atresia can be successful in 70% of patients to establish bile flow if performed in the first 60 days of life. After 90 days, less than 25% of patients will have bile flow established. The total serum bilirubin predicts the outcomes in biliary atresia. Overall, of all patients who receive this operation, 50% have a bilirubin of less than 2 in the first 3 months of life. Transplant-free survival at 2 years is significantly higher in those with a bilirubin less than 2 compared to those with a bilirubin greater than 2, 86% versus 20%. Infants with bilirubins greater than 2, moreover, have diminished weight gain, greater probability of developing ascites, hypoalbuminemia, coagulopathy, needing a liver transplant, or dying. Another targeted therapy that has recently been described is a compound called 4-phenylbutyrate, which has been shown to be helpful for one of the PFIC disorders, PFIC2. Tyrosinemia, once identified, can be treated with its antidote called NTBC, nitisinone, or orfidin, 1 to 2 milligrams per kilogram, and this reduces and prevents succinyl acetone from building up in the plasma, which is the toxin for the liver. Dietary therapy is also offered. Treatment for cholestasis also means supportive care. It means appropriate nutrition, vitamins, choleretics, antipyretics, diuretics, and surgical options such as transplantation and biliary diversion. This is what biliary diversion means. It's done generally for the symptom of pruritus and specific diseases. Here's the gallbladder. A jejunal limb is constructed and a stoma. This drains the bile and it's discarded so that it does not proceed down the intestine and then get reabsorbed and then have to be reprocessed. So it interrupts the enterohepatic circulation of bile acids and decreases the influx of bile acids into the gut, leading to less reuptake. We mainly use it in Alagille and selected PFIC diagnoses. Malnutrition. Malnutrition occurs in these cholestatic disorders because of catabolism, early satiety, malabsorption. You need bile and bile acids to absorb fat and fat-soluble vitamins. Children are both short, they have decreased production of growth hormone, and they're underweight. Specifically, they have deficiencies of vitamins D, E, A, and K, zinc, iron, often from gastrointestinal bleeding, and electrolyte disturbances from diuretics. They have delayed puberty, and bone health is a major manifestation. Strategies for improving nutrition, in addition to evaluation and identifying that it needs to be improved, include specified formulas that are semi-elemental infant and pediatric formulas that contain medium-chain triglyceride, which is more favorably absorbed in cholestasis, and modular things like specific carbohydrates and fats and isolated MCT oil to add to these formulas to increase calories and to add things that are better absorbed. Tube feedings are often instituted, and finally, when all else fails, parenteral nutrition. Future challenges. Improvements in outcomes of cholestasis are not likely to be from improvements in surgery. We already know how to do these operations. We have experts that can do hepatoporta enterostomies. One of the major things in improvement since biliary atresia is the number one reason for liver transplantation in the world is earlier diagnosis of this condition so that we can move to earlier hepatoporta enterostomies. Progress will be made in a search for etiology, particularly in exome sequencing and in the metabolic and genetic area. We search for specific disease therapies and cures. I challenge you to go out there and make earlier diagnoses, refer your patients so that we can continue to try to make a difference for the patients in our community and our referral area. Thank you.
That was quick.
Linda, excellent presentation. Your NASPGAN doesn't talk about the exclusively breastfed infant. And at what point, how many weeks of age, et cetera, is there such a guideline?
Yes, that's an area of some flexibility. However, it's not recommended that you wait beyond 3 weeks of age to evaluate the breastfed infant. And there is actually, it addresses, I didn't present it specifically, but it does address this. If it's a breastfed infant and it's customary to have that checkup for that baby at 3 weeks of age, then it's acceptable to measure the total and direct bilirubin at that checkup. If the baby is demonstrated to have jaundice. Is that local practice to see them at 3 weeks?
We usually see them at 3 or 4 days and then at 2 weeks of age.
So you would fall into the guideline of if they're jaundice at 2 weeks to determine direct bilirubin.
Linda, you were referring to earlier diagnosis. Do you have any idea about how many cases are missed or late? What's that diagnostic time? And what would be gained with earlier diagnosis?
So what would be gained by earlier diagnosis is the Kasai hepatoporta enterostomy by 60 days of age. And actually, it's been shown that you can line up effect of the Kasai by how early it is, with the highest results being at 1 month, then the next is 45 days, 60 days. And by the time you get down to 90 days, we have a very poor result of less than 25%. And well over 90 days into 4 months, most people will not even try the Kasai operation because the outcomes are so poor from doing that, and the child likely has portal hypertension, and the surgery will be very difficult. So it's all related to outcome of the Kasai.
What is our local experience? What's our median mean time of diagnosis in our community?
We see about a third of our patients at least after 60 days. and about 10% after 90 days.
So if we're evaluating a newborn with physiologic jaundice, we get lab work, and they have a mostly indirect hyperbilirubinemia, but the direct bilirubin is over 1. What do we do with those babies?
Well, the primary care provider can certainly initiate a workup from the specific tests that we've talked about, check the newborn screen. I would recommend in general that there's a hotline right to the liver center. You call and we'll talk out the problem with you. Those patients generally should be referred. And we will talk with you about tests that could be office-based tests that would be helpful to have when we first see the patient. But we have not just an isolated approach. We would be moving forward with an ultrasound, and depending on the age of the child. I recently had a child referred by one of the local providers in this area really at 4 days of age because the direct bilirubin was 2. And this child ended up having biliary atresia. I was able to pace the evaluation, but the child had its Kasai operation by 1 month of age, and it's successful. So this can happen. I'm hoping you'd have some comments, Ted, about bilirubins, and feel free to take the floor.
Well, no, thank you. Great presentation. The normal range for conjugated bilirubin or direct bilirubin is 0.5 and below, and that's even a high normal range. I mean, it is if it's 1 or 2, I think the next thing is to get the kid to a gastroenterologist.
Yeah. And I'd like to add with that comment, when we look backwards at all the patients that get diagnosed with biliary atresia, when bilirubin levels are available in that neonatal period where they were getting bilirubins in the nursery, there is an over 95% association with an abnormal bilirubin level. It may not have been 1, but it was in the abnormal range of above 0.5. And this is another screening strategy that is being discussed for not necessarily doing a gigantic workup, but at least following those babies that have an abnormal direct bilirubin to see what direction they go.
I had a question about that third that get missed and are late diagnosis.
That get the late-
what are the factors that lead to that late diagnosis?
I'll give you my opinion and what's kind of written about there. Some infants, as you know, are missed, and aren't followed. There's missed follow-up. I think that there is largely, occasionally, there's lack of recognition that the direct bilirubin elevation needs to be evaluated further. There is often misinterpretation or lack of recognition that the stools are pale and it's abnormal. There may be lack of recognition of jaundice, particularly in people of ethnic descent. It is known that African American babies tend to have, sometimes in some communities, a later Kasai because you have to look at their eyes to see the jaundice, and it may not be recognized because jaundice doesn't show up through skin pigmentation in some of these people. So it's multiple things. Yes?
Other than timing of the Kasai, what are there known risk factors for who might go on to fail and what we need to watch for in the post-op period?
That's a really good question, and we know that some children, despite the fact that they get a timely Kasai, do not do well. And there are different phenotypes of biliary atresia. Some are more fibrotic, Some are not going to work. It's said that in general, the congenital forms may not have as favorable a response to the Kasai operation. That premature babies who are premature may not have as favorable response to the Kasai operation. This is also an operation that needs to be performed by a very experienced surgeon. In England, they have restricted the performance of this surgery and evaluation of cholestatic babies to 3 major centers. And they do now have some of the best results in the entire world in evaluation and treatment of biliary atresia. And I believe we're going to be doing, aren't I correct, Steve? That's one of the things you're looking at in the children's study is what genetic abnormalities may be present from exome sequencing that would predict that you have a genetic abnormality that would predict a poorer result from treatment than someone who has a different genetic abnormality. So these are things that are all in the pipeline. It's a good question.
How many new diagnoses of biliary atresia do we have here each year? Any idea?
It varies, and interestingly, they cluster. We've described about 20 years ago the clustering of cases at that time, more in eastern Idaho than in the Salt Lake area. But on average, we have anywhere from 3 to 8. And you will see one after another, maybe from different parts of the referral area, but still they do cluster, strongly suggesting that perhaps there is some environmental impact on this disorder.
Any other questions?
Would you all rise and join me in thanking Linda not only for this presentation,